So welcome to the first Caduceus Club Journal Club. This journal club is going to be primarily focused on healthcare. Today, we're going to discuss a paper describing the effects of ketamine. The paper is called Ketamine for the Acute Treatment of Severe Suicidal Ideation. It's a double-blinded, randomized, placebo-controlled trial. A couple of others have been conducted, but this one is the most novel. It's published in the British Medical Journal. And seems to have seems to be pretty popular. It's a great introductory journal article to go through. So if you want, you could track the attendance, get a point for being here, and I'll give you guys a couple seconds to do that. All right, we'll get moving here. So what is the journal club? So the purpose of the journal club is to introduce you to published literature, right? A lot of you may maybe first year students, or underclassmen that are new to research. This is a great way to get introduced to how journal papers are structured, how to break them down, and how to go through it and read literature. Since we're in the Caduceus Club, this is going to be healthcare focused, but there's also other journal clubs within research laboratories. If you go into a more technically focused journal club, they might go over materials papers, electronics papers, stuff like that. Or if you go into a more social policy healthcare journal club, they'll go over policy implementation papers. So there's a variety of stuff. And you'll see these journal clubs, they're not as popular in undergraduate study. And that's why I want to kind of expose new undergraduates to them, but they're more popular in the graduate field when a lot of labs, they decide to have their own journal clubs, weekly, monthly, bi-weekly, stuff like that. So there's low stress, there's no repercussions here, no judgment, and it's not going to affect any research outcomes. A lot of people are nervous because they have to present to their PI or something, but nobody's here. So we're really here to just discuss the literature, the research, and to learn from it and practice our research skills. When you're participating, make sure you skim the article. If you have any ideas about the article, make sure to share it. So these are just some expectations. Of course, you don't have to do it, but it's great if you bring your own perspective, because we love to hear what you have to say. But without further ado, let's get into the research. So a little bit about the background. If you guys don't know, placebo is a treatment. So they're testing a main treatment. The placebo is going to be their negative control. So they're expecting no results from it. But what a placebo can do is that if any patients want to take a treatment and they think that it is a treatment, they might have a psychological effect. And so this controls for that psychological effect. Double blind means that the participants and researchers don't know which subject gets treatment. In this case, only one person knew in the entire study, and that was a coordinating nurse. So she was the one who distributed out the treatments, whether it was ketamine or whether it was a placebo. And ketamine is a non-competitive N-methyl D-aspartate receptor antagonist, and it disrupts glutamate at high doses. So that's why it's mainly used as anesthetic, but they have found that in lower doses, it may stimulate glutamate receptors, and this might offer new pathways into the brain, right? Since a lot of depressive disorders or other mental disorders suppress the brain, this might be able to excite the brain into its normal state. Suicidal ideation is a broad term used to describe a range of contemplations, wishes, and preoccupations with death and suicide. So this was the primary measure of the study. What's the effect of suicidal ideation on patients after they received this low dose of ketamine treatment, right? And this was analyzed using the Beck scale. And the Beck scale, what it is, it's a questionnaire, and it pulls from all these different diagnostic criteria to determine your the amount of suicidal ideation that you have. So there's point scales assigned to it, and I believe their marker for suicidal ideation was a scale above a 3. So some statistical terminology that you should be aware of is called a superiority trial. It's going to evaluate the effectiveness of a treatment. So it is evaluating the effect of ketamine versus placebo. So that's the superiority trial. They use for statistical analysis for determining if it was significant. They used two-sided alpha risk number of 0.05. And that means, so you have your distribution here. Here's an example. And if it's 0.05, you'll have 0.025 on the higher end of your data distribution, and the 0.025 on the lower end of your data distribution. If any of the data falls beyond those, or beyond the 0.05, then it would mean it was significant. So why was the study needed, right? So there's a lot of other meta-analysis. So meta-analysis being, these are papers that take in all these different studies on the effectiveness of ketamine. So there was a different paper that did a meta-analysis of it and analyzed the effectiveness across multiple studies. However, a lot of these were really small sample sizes. So these were in the tens of patients versus this study, which had 156 patients that were participants in the study. And also they wanted to see what the effect on other disorders. And what we'll see later is that there's a great effect on bipolar disorder with ketamine treatment. And we'll go through the breakthrough of how these participants were recruited, right? And how they went through the study. So this is kind of the pathway of how how the participants went through the study. There's the placebo and then the treatment group. They some discontinued treatment at different ends, and then yeah, it basically shows the tracking of the patients. And then you'll see is that 66 of the placebo group stayed with the trial, and then 60 completed the trial with the treatment group. Some of the methods. So what the treatment was it was a 40-minute ketamine injection IV. This is 0.5 milligrams per kilogram body weight, or the placebo, which was 0.9% saline. This was followed up by a second dose 24 hours later. So there's evaluations. So there's the Beck scale evaluations and other symptomatic evaluations spaced out throughout the study. So these evaluations are at 2 hours, 4 hours, 1 day. So this was before the second ketamine injection. 2 days, 3 days, 4 days, 2 weeks, 4 weeks, 6 weeks. And then 6 weeks was the end of the study. And that was the final marker of what they did for the results. And what they found is that the results were pretty cool, right? So this is a time scaled down to 3 days. What you see is that there's a massive remission rate. So suicidal remission rate, let me orient you on the graph. Suicidal remission rate, so this is the rate of patients not having the suicidal thoughts. And if you have a higher suicidal remission rate, that means more patients are not having suicidal thoughts. So it's a positive result going up on the y-axis. And then the time since they were given the treatment. So time since inclusion is a little different, right? So they'll be included in this study, then they'll be given treatment. So the time 0, I believe, is a little bit after they were marked as inclusive on the trial. So what happened is that after this treatment, you'll see in a very short time period, the remission rate of the ketamine group went up drastically, and that's amazing, right? And you see this placebo group kind of slowly going up. I'm no expert in mental health or suicidal ideation, but time I think likes to heal a lot of things. So maybe the time and patients being in a supportive environment. This is this wasn't just out in somebody's house. This was like in a hospital setting. So maybe that supportive environment contributed to the gradual increase of suicidal remission or suicidal thought remission. And you'll see a time, the time is extended to 4 weeks. So this is to the end of the trial, the 6-week marker. And you'll see at the same point, that first week, the first couple of days, you'll see that big jump, and then you'll see another big jump, and it kind of held steady, right? And what you see, even if you're not looking at the statistical analysis, there's a 20% gap in some places between the remission rate of the placebo group versus the ketamine group. And that's what they saw with this large sample size, is that it's a significant increase. So the paper then goes on to discuss some of the implications of this, right? So we will see is that at the 3-day mark, these are quantifiable data now. There's 63% remission at 3 days versus 31.6% remission in the placebo group. And then at even a shorter time frame, you'll see 43.8% remission versus 77.3% in the placebo group. So it's almost an immediate effect in 2 hours that you'll see the patients they'll be reevaluated on the Beck scale, and their suicidal tendencies, or not, sorry, suicidal thoughts will have been decreased. So what they saw besides this, right? So they did evaluate for suicidal thoughts, but there's also some effects on mental disorders, right? And the biggest result that they found, they didn't find too many results on depression or other disorders, but what they found was bipolar disorder. And there's a significant decrease of the symptoms of bipolar disorder after using ketamine, or after being given this treatment, and it wasn't significant with the others. So a really big discussion that they had after this, right, is that there is a difference between suicidal thoughts and suicidal ideation. The suicidal thoughts, even though they went into remission, there was between the two groups, there was still a very similar rate of attempted suicide. So this is after the treatment. So 8.2 versus 9.8. So this treatment versus placebo, they did attempt suicide, with one being fatal. So what they saw is that even though the suicidal thoughts might have gone down, the suicidal attempts were fairly steady. So this might be another gap to address, right? If you have this treatment, how further along the line, how can we help these patients maybe decrease the rate of attempted suicide? And that evaluation of that, another research study might be needed to see what's the best way to do that. What's the best way to provide supportive care for patients who may have overcome the suicidal thoughts, but will still they still might attempt suicide in the future. A couple of limitations. So the analysis of these patients were conducted in smaller groups, right? These weren't all conducted by the same physician or clinician. These were conducted by a group of clinicians diagnosing and evaluating smaller sample sizes of patients. So there might be some variation within that. And so that's why there's a limitation on this study. The second limitation being masking may have been compromised. So masking being usually with ketamine, there are some noticeable side effects. And patients that might have recognized these side effects may have known, oh, I had the ketamine treatment, right? So they might have responded differently with the while knowing that they're on the ketamine treatment. A good control that was proposed was this drug called midazolam. I hope I pronounced that right, but it might mimic the side effects of ketamine, and it might be difficult to distinguish between patient groups if they've had ketamine before and they can recognize it. So it might be better as the control versus 0.9% saline, which was used as the control in this study. And then, as I said before, this paper also did not equate suicidal thought reduction to reduction of suicidal acts. And that is a great area of study if one was to look at the future implications of how do we support these patients after treatment, after this ketamine treatment. So this is a very basic study, but it's a great way to get introduced to research, right? You have a regular superiority trial, you have a control group, you have your treatment group, and there's a great evaluative criteria, right? If you go through this paper, there's several different evaluative criteria. They track the characteristics of the patients, right? All of them didn't just have suicidal thoughts; they had other disorders. They tracked the symptoms. They tracked the how the patients went through the study really effectively. There's great infographics supplemented by the British Medical Journal, right? So this is a wonderful paper to get started with, and uh, you know, all papers might not be as laid out and as transparent as this one, but this is a great one to get started in, get your feet wet. And I hope you had a chance to read it and enjoy what you're reading, and hopefully you learn something from evolving medicine. So with that said, anybody have any questions?
I just have a question regarding the the groups. So I know that there's a placebo group and the group that received ketamine. Were they all going through the same processes in terms of receiving external treatment? So maybe like therapy or counseling to overcome with the pre-existing mental disorders?
I'm not sure, but I think in the method section, there's the patient section right there. And it says they were admitted into the hospital with suicidal ideation. So I'm not too sure specifically why like the supportive treatment that were given. Like, this says that they were French speaking and they're voluntarily admitted to the hospital.
Okay.
Let's see if there's any other information on any other supportive care. I don't see any other
Okay.
details on that.
Okay. I was just curious because like that could also have contributed to the differentiating data.
Oh,
So
definitely, yeah.
yeah. Mhm.
Yeah, so I think that'd be a valid criticism of the study, right? If they were able to give some more details on the extent of supportive care, I think uh, it would be just another controlled variable, and ultimately contribute to better data.
Okay,
So that's
sounds
great.
good. Thank you.
The most interesting part of the study to me is the fact that although suicidal thoughts overall decreased, there was still about the same levels of suicidal acts. So it kind of makes me wonder if the ways that we measure suicidal ideation are not necessarily as accurate as they could be, to indicate whether somebody might attempt a suicidal act. Um, and I'm wondering if maybe there's some way that we could improve that in the future.
Yeah, that'd be pretty cool if we can see. Yeah, there's definitely the disconnect, and it's unfortunate. So maybe the Beck scale isn't the best informant on or best predictor of suicidal actions. There might be a way to, yeah, maybe improve that evaluative criteria, especially right when, at least in the United States, this is done in France, I believe, or Canada. At least in the United States, you're at least in California, where I'm from, 5150 is the code for psychiatric stays, and there's a procedure behind that. But with these stays, I'm not too sure if they use the Beck scale. If they use the Beck scale, is it a great predictor, right? As you said, of suicidal acts. So if there was a criteria being implemented, maybe that would also be placed in the protocols for 5150 and patients that were undergoing mental health emergencies. And I think that would be a great way to decrease fatalities and overall, help these patients with what they're struggling with. So great input.
Kind of going off of that idea, I know that a part of mental health disorders is kind of masking the symptoms in order to, like, a part of having a mental health disorder is that the disorder wants to disguise itself, so that the person doesn't reach out for help and those sorts of things. So I'm wondering if maybe one of the side effects of ketamine could have kind of increased the levels that these people were masking their symptoms, or maybe it did kind of reduce their symptoms, and so then they weren't necessarily reaching out for help as much as they normally would have. Of course, I don't know what these people were thinking, but it's just something that I was wondering about reading this.
Yeah, I was looking in the discussion section. They might have mentioned something similar, right? Where maybe there's some type of masking. Yeah, I'm right now. I'm looking at the second to last paragraph in the discussion section under principal findings. So a couple other things to add, right? Let's see. With your thoughts of masking. So the detailed exam. So I'm just going to read off of this. The detailed examination of these events in the intervention group showed that A, none of them had exacerbated depression or suicidal ideation scores after infusion, suggesting that ketamine had no direct negative effect. All these patients were poor responders to ketamine in the first 3 days. And some of them had finally reached remission of suicidal ideas after several days, which may have led to decreased vigilance. So I think I did remember reading that sentence, and that might be kind of what you're saying, right? Where maybe that decrease in vigilance is that masking that you were talking about. But of course, yeah, I don't know. I don't know if you, yeah, I don't know if you know, but that might be something to look into, right? What are some things that, off the top of your head, maybe would be a better way of detecting that masking? Do you think, at least off the top of my head, maybe keeping them in that supportive environment, but taking them off ketamine, see if their symptoms or the suicidal ideation comes back, even though it might be a little unethical, right? Taking them off the treatment that's making them feel and think that less, or seeing if that's curing them or it's masking the symptoms, right? Do you have any other input on that?
Yeah, I think it might end up going back to what Grace was saying about seeing if people are still receiving the same levels of counseling or outside support in addition to the ketamine treatment. Because although they might be like experiencing an alleviation of symptoms, maybe then once some of those symptoms start coming back, they don't really know what to do. They've kind of lost some of the external support because it wasn't really viewed as needed anymore, and that can kind of put them in a tricky situation. So maybe a more long-term external support system in addition to the ketamine treatment would kind of help to kind of eliminate some of those discrepancies in the results that we saw. But yeah, that's all I can think of for that.
Yeah, great. I totally agree with you too, right? And the study also further goes on to say to recommend, right, not just the pharmacological therapy, but also psychological, social, and family care and support.
I think that something that could also have contributed to the fact that isn't very much difference in terms of suicidal attempts is the fact that both groups contained individuals who have been suffering mental illnesses. And it could have been that suicidal attempts is something that isn't a drastic of a measure for them. So given the same precipitating event, um, it could have been that it was just the easy decision for them to make because it wasn't so foreign to them. And so even though ketamine may have decreased those suicidal ideations, eventually when that precipitating event happened, they sort of like could have went back to that easy solution just because it's not something foreign to them. I just don't know like what progress of mental illness these individuals are in. So yeah, that's another factor that could have contributed.
Yeah, definitely. And I think with your thoughts on it, I think the maybe the most appropriate study with evaluating to see if um those individuals they how they process thoughts, how they thought of suicide, whether it's an easy or hard decision. Maybe that'd be a good case study, right? Because there's a lot of these larger superiority trials with these treatments, but maybe using this treatment study, they're able to then prescribe these treatments to patients, and then while they're doing these treatments in a controlled setting, they're able to do a case study. Let's see the specifics on the patients. Let's gather some data. Let's gather what's their previous symptoms, how far are they along in their mental 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 state, mental health struggle, right? How what's progression, and seeing how they're able to respond, and seeing how their thoughts might change, right? But that's I personally think maybe that's a little difficult to do in maybe in this large of a study, but that would be really appropriate for a case study. Yeah, because we do the scientists do case studies all the time on physical treatments, but maybe there might be more efforts put into case studies with pharmacological plus mental health support treatment, that type of thing. So that might be interesting to read about in the future.
Yeah, I think that's really interesting because like with depressive disorders and different mental health disorders, there's a pretty wide range of symptoms that people can experience. And maybe it's not necessarily that you're having suicidal ideations every single day, but the moment that it does happen, it doesn't matter how many times you've had it in the past. It's just such a severe experience that it doesn't it's not necessarily something that you have to have so many times in order for it to become dangerous. It's something that is dangerous even if you have it one time. So I think that might be something interesting to kind of see, like the correlation between the amount of times that people are having these types of ideations versus how like intense like it makes that desire to act on them, if that makes sense.
Yeah, definitely. To play the other side of your argument, right? Even though I'm not going to discredit your point, but maybe the Beck scale does cover those evaluative criteria. Hey, over this 6-week period, how many times have you thought about suicide, and the thoughts surrounding that? I also think that it might be the case that it did mention in the paper that these patients, they didn't respond well to ketamine. Like not everybody responds well to treatments that are for mental health, right? Everybody has a different brain. Everybody has a different response to mental health treatments. Maybe it's just the case that ketamine just didn't work for them. It wasn't an effective treatment. And since this was a controlled trial, they were probably only put on ketamine as their treatment to prevent other interfering drugs. And that might have contributed to the decreased effectiveness of ketamine, and maybe down the line their attempts at suicide. So even though this might be a problem with suicidal ideation being overpowering and stuff. In terms of the paper, maybe it was just ketamine didn't work for them. It might be that it just wasn't that it wasn't that level of treatment, right? Because and to add on to that point, right? Ketamine, even the traditional SSRIs, they don't work in 70 and sorry, not 75, in 25% of American adults, right? Some people have, at least with depression, uh, uh, treatment resistant depression, and that was, don't quote me on that, but I did read it in a couple, and I saw it in the video or something on that statistic. So maybe just we need to search for ways to find the best treatment for an individual, and that might be, and it's totally the case that it might not be ketamine.
Yeah, did the paper say, because I know it said like this percent of people went into remission after having the ketamine treatment. Did it say if the people who then attempted suicide were a part of the group that went into remission, or if it was like a part of the population that it didn't really work for them as well as it did for others?
So I think in the principal finding, second to last paragraph, let's see, detailed examination of events. Let's see. Okay, so some of them finally reached remission of suicidal ideas after several days, which may have led to decreased vigilance. I mean, it doesn't sound very clear to me whether or not they did reach remission in a certain number of days.
Yeah, that might
Yeah,
be another thing that they could have included in there.
definitely. I agree. All right, cool. Well, it's been 30 minutes. So with the journal club, in the future, I hope, if you have any other interested individuals, maybe not even in Caduceus Club, but other organizations that are interested in this type of healthcare journal club, reading articles, evaluating them, invite them here, right? It's 3:30 on a Saturday, no longer than 1 hour. So if they're interested, please encourage them to join. I'm planning on doing maybe 2 articles a session, one every 30 minutes, 20 minutes, 10 to 20 minutes for presenting and 10 minutes for discussion, that type of thing. But we'll see. It's still fluid. It's still new. So I'll make a judgment call on the organization of it. But do you guys have any questions for me before I wrap this up?
Do you plan to keep the format of the discussion this way, where we sort of like present the entire paper and then ask questions, or sort of keep it an open discussion so that like while we're running through all the steps of the paper, anyone's open to ask questions? Or like, what are your thoughts on that?
Yeah, I think it would be better to do what you said, right? Let's go through the methods. Is there any questions about the methods? Let's go through the results. What's any questions about the results? So I think that might be a great way to present this information. Yeah.
Okay, sounds good.
And are any of you interested in presenting next month? I think this is going to be a once a month thing.
I can present next month.
Awesome. Yeah, I'll just shoot you an email, and it'll be the same format as this presentation, just a couple of slides, and then just run through the paper,
Okay.
whatever paper you want to present on.
Got it.
I was going to ask if we were allowed to suggest papers that could
Oh
be
yeah,
presented.
sure. Shoot me an email if you have a paper that you think would be interesting. I could ask the mailing list, say, hey, does anybody want to present on this paper? Or if you really find it really interesting, and you have that, if you have the desire to present on that, you can do that as well. So yeah, shoot me an email if you find a cool paper that you want to discuss.
All right, cool. Thank you.
Okay, other than that, I'm gonna end the recording. I'll